So to kick off our mental health chats, I kind of threw it out there if we wanted to discuss either schizophrenia or bipolar disorder. So somebody chose schizophrenia, so we're going to be discussing schizophrenia. And again, this is going to be not a super in-depth discussion, but we will be talking about different things. So just what the diagnostic criteria looks like, I'll be kind of running through that, as well as some of the things that are believed to cause it, and what some of the treatments are, and really just I'll be kind of throwing in additional little nuggets of information that I've come across through my own studies while being in school. So the diagnostic criteria comes from the DSM, or it's also known as the Diagnostic and Statistical Manual of Mental Disorders. So if you're not familiar with that, I actually have it. Let me show it to you because it is huge. So this is what it looks like. I actually have the latest version as well, which is it's this right here, the text revision. So it does include some revisions. It is a lot, and I'll show you guys. So I actually have like tabs, and it organizes everything very neatly. So it's a lot of information, and as the years pass and as research grows, they continue to categorize it differently, organize everything differently. So I have access to it virtually through my school, but I think it also just really helps to have this. So I actually have this giant book, and I also have like a smaller, like pocket book almost, that kind of gives a less detailed description of all of these disorders. So this is the latest one, the text revision, and this is where I pulled all of the criteria from. So in this version, schizophrenia is listed under schizophrenia spectrum. I can't even talk. Schizophrenia spectrum and other psychotic disorders. So just to kind of run through some of the other disorders that are included as part of that spectrum is schizotypal, delusional disorder, brief psychotic disorder, schizophreniform disorder, schizoaffective disorder, substance medication induced psychotic disorder due to another medication, and catatonia associated with another mental disorder. So as you can see, there's a lot, and there's a lot of similarities within a lot of these. Obviously, I'm not going to be talking about them since we're only focusing on schizophrenia today, but it is part of that category. So to kind of walk through some of the features that define psychotic disorders, the first one is delusions. So delusions are known as fixed beliefs that don't change even when there's conflicting evidence or enough evidence. And this can include persecutory, referential, somatic, religious, or grandiose beliefs. And I'll kind of explain what some of those are. So persecutory, it would be like when a person feels that they're going to be harmed or harassed by someone, such as like an organization. And this is the most common delusion. Referential is believing that when people make certain gestures or comments, or there are environmental cues that are directed at them even if they're not. Grandiose is when somebody believes that they are exceptional, that they are like above other people, just they have more wealth, they're famous, things of that nature. Erotomantic delusions is when somebody believes falsely that another person is in love with them. Nihilistic delusions are convictions that a major catastrophe is going to happen, so kind of like end of the world type stuff. Somatic is a preoccupation with health or organ function. So this would be like a just kind of being like thinking that, being kind of paranoid, I guess, about your organs, your internal functioning, and anything that's deemed bizarre would be something that's not easily understood by others. So I do want to point out that the DSM is very good about outlining that something is bizarre even if like within the same culture those peers wouldn't understand, and it's out of the ordinary, because that's very important to keep in mind, because cultures are so different. So something can be very normal in, I don't know, I mean, just Mexican culture, me just thinking some Mexican, something could be very normal in Mexican culture, but it just seems so weird to, I don't know, Armenian culture or something like that. So this would be more like, if within your same group, if it still doesn't make sense, if it doesn't align with the typical practice, that's what is considered bizarre. So it doesn't mean like, if the clinician doesn't understand it, it's bizarre. There's no, that's not what we're talking about. So something that's also bizarre would be like, if somebody believes that there's like a force that's removing their internal organs and replace them with somebody else's, when there's no type of visible scars or anything like that. Something like that is deemed bizarre because there's not enough evidence for it. It doesn't make sense. A non-bizarre delusion is when somebody's thinking that, an example would be if somebody is thinking that they're under surveillance, even if there's no evidence for it. So I think it's also important to remember and consider that there's a lot of nuance when it comes to this. So the clinician or therapist has a lot of responsibility in making sure that they've familiarized themselves with the client's culture and their cultural practices. And that's something that is embedded within the ethics code of being a clinician. So that's something that I always keep in mind. We really can't, it's not the clinician's role to assume that we know more than the client. So that's one important thing to keep in mind. I know I kind of went on a rant about delusions, but that's the whole section about delusions. So the next one would be hallucinations. So a hallucination is defined as a perception-like experience that occurs without any form of external stimulus. So from the person's perspective, they're very vivid and the person is unable to control them. So for schizophrenia, an auditory hallucination is the most common. So they're hearing things that are very, very real from their perception, even if they're, it's not normal, it's not there, but it is something that is very real to them. So they can hear voices that could be familiar or unfamiliar, but it's a very separate identity from their own thoughts. The next criteria for psychotic disorders is disorganized thinking or speech. So there's a severity component that occurs with this diagnosis because impairment would be significant enough to affect someone's ability to communicate. And so this is separate from something like speaking in tongues, where it's part of like a religious practice. This is not being able to communicate effectively, like the thoughts are scattered, things like that. Then grossly disorganized or abnormal motor behavior is the next one, and this also includes catatonia. This can be manifested in many different ways, such as, somebody is being very silly, if they're acting very childlike, and then they become very easily agitated, or there's a lot of like unpredictable behaviors. And then catatonic behavior on the other end of that is when there's no reaction to the world around them, so they're kind of very detached. So it can be seen in the form of not following instructions, which would be like negativism, bizarre posture, no verbal or motor responses, so mutism or stupor, or catatonic excitement, which would be like pacing around the room, showing agitation without anything being the cause of it. It just sort of happens unpredictably. And then the next one is what's known as negative symptoms. So when we talk about negative or positive symptoms, it's not the same as what we think is like a negative or a positive emotion. So negative emotion would be like, oh, you're sad. Positive emotion is like you're happy. So when we're talking about negative or positive symptoms, it's very different. So negative symptom would be more like there's a lack of, so there's like a lack of emotional expression. So there's no like hand gestures that show excitement. There's no emotion in somebody's face. There's avolition. So there's kind of like inactivity. You don't engage in activities, or you don't have an interest in it. Anhedonia is also a decrease in experiencing something that brings you happiness or pleasure. And people with schizophrenia can do something in the moment and enjoy it, but the thing is they may not always want to engage in it very frequently. So on the other side of that, I mentioned that, there's also positive symptoms. So a positive symptom would be something like hallucinations, where somebody's experiencing a change in behavior or thought. It's kind of like something extra that happens that doesn't happen in what we would consider like the baseline of human behavior. I don't like using the term normal. I like using kind of baseline. I think that's a bit more accurate, because it's like, who says what's normal, right? So that's kind of why I use the term baseline. So that's kind of like what defines psychotic disorders. And one thing that I want to mention about the symptoms of the schizophrenia or the schizophrenia spectrum is that usually for men, they typically see these in the late teens or early 20s is when you start seeing some of these symptoms. And for women, it actually comes a little bit later, which would be during like the early 20s or early 30s. So now with that kind of background understanding, so now this is the actual diagnosis of schizophrenia. So for the diagnosis, there have to be 2 or more of the following that are present for a significant amount of time during a 1-month period. So 2 of either delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. The second part of the criteria is that the person's functioning at work or with their personal relations, so like family members, romantic relationships, any interpersonal relations, even their self-care, are far lower than what was occurring. Seth!
Silly eyes.
Hello! Hi, friend! How is your day going? Now, where was I? Oh, thank you so much for that shout out for Says. Okay, now where was I before Says rudely interrupted? Just kidding, not rudely. I'm so happy you're here, friend. What was I say? Okay, yeah. So the second criteria is someone's, functioning with their relationships at work. Their self-care is significantly lower than what was occurring before there was an onset. And then disturbances last for at least 6 months with at least 1 month of symptoms. Or they could actually be less if the person is receiving treatment for it. And they can include periods of prodromal or residual symptoms. So prodromal is when the signs or symptoms or change in behavior occur right before a psychotic episode. So this would be like issues with memory or paying attention, not being able to focus, mood changes, depression, thoughts of suicide, anything like that. And then residual is when the individual experiences less symptoms or they're less severe than when they were in the active stage. Another part of the criteria is that schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out. So there's a lot of like cross-referencing between some of the other conditions. And then also the disturbance isn't related to any other substances, so like any kind of drugs or medication, or other medical conditions. And the last one indicates that if the individual has a history of autism spectrum disorder or communication disorder of childhood onset, there can only be a schizophrenia diagnosis if there are prominent delusions or hallucinations on top of all the other required symptoms for at least 1 month. So then there's also some additional like specifiers that can be used after 1 year of duration, and catatonia would be specified there as well. So as you can see, there's like a lot of considerations and there that a clinician has to keep in mind to properly diagnose somebody with it. Because like I said, there's a lot of similarities between the other schizophrenia spectrum disorders. But yeah, I didn't include everything in the DSM because it is a lot. And I was like, okay, I should probably try to keep it a little bit simple. So okay, now we can move on to what is believed to be some of the causes. So what causes schizophrenia? And unfortunately, there's not one direct cause. So there are several hypotheses out there. So one of them is that schizophrenia is correlated to dopamine levels in the brain. So dopamine is a neurotransmitter that plays a role in pleasure, satisfaction. So it's kind of like a reward system. So the dopamine hypothesis states that there's a lot of dopamine in the striatum, which is kind of like a deep brain nucleus that is responsible for some of our motor movements and simple motor tasks such as making decisions, forming habits, and so on, and the mesolimbic pathways. So this transports the dopamine. The hypothesis also says that there's a decrease in dopamine in the prefrontal cortex, which is responsible for our executive function. So this would be like paying attention, so being able to focus and pay attention, impulse control, managing your emotional reactions, and planning ahead. So that kind of makes sense when we're, talking about some of the negative symptoms, where people can't really focus or a little bit more detached. So the dopamine hypothesis is the most prominent one that's out there, but the thing is that it doesn't fully explain everything and it doesn't explain all of the symptoms. So that's why it's not the only hypothesis that exists out there. So it doesn't explain enough because there's about a third of patients that don't respond to drugs that block dopamine. And if it did explain it, then it would mean that it would work for everybody, right? Because if you're managing the levels of dopamine in the brain, then you would think it would explain everything. But that's the reason that there's more than one hypothesis out there. So the next hypothesis has to do with abnormalities in glutamate and its receptors. So glutamate works with memory, the sleep-wake cycle, the signals for pain, and it does a lot of things. Everything in the brain does a lot of things. So I'm not covering everything because the brain is very difficult. It's a very difficult and very intimidating thing to learn. I'm very intimidated by the brain. But anyway, because of the abnormalities, it's also believed that it could be the cause of some of the negative symptoms in schizophrenia. So it can also explain, it kind of like bridges the gap or closes the gap and explains things that the dopamine hypothesis does not explain. And I didn't go into full detail about this theory because I think it would also just be a much longer conversation and I would have to explain like several neurotransmitters. So I'm like, so I think that's probably the easiest way to explain it, is that there's some abnormalities in the brain and as it relates to glutamate. That's probably the easiest way to explain that. And some additional potential causes include they're due to evidence that there are some abnormalities in the brain from schizophrenic patients. So especially in the hippocampus, which is also involved in like memory, emotion, and learning, and the amygdala, which processes the emotions and detects danger, among many other things. So some researchers think that this happens early in development. Additionally, there's research that also indicates that there's a genetic component to this, but there's not one single gene that's responsible for it. So there's nothing that they've determined is like okay, this is the actual cause of it. So it is caused by a lot of different things. There's a lot of different hypotheses out there. So I will say that there is a bit of a genetic component, as I just mentioned. There's a higher likelihood of developing it if it runs in your family. So just think of it as you can be a little bit more susceptible to developing schizophrenia, but it's not actually guaranteed that you'll develop it if there's genetics involved. So in twins, actually, if one of the twins, it's been found that if one of the twins has schizophrenia, there's a chance that the other one could develop it, but it's not a guarantee. So there's kind of some like, I don't want to say vulnerabilities. What did I say earlier? Not vulnerabilities, but you're more susceptible to it. So there's, like I said, not one exact thing that causes it, but they have looked at the brain, they've looked at genetics. There's also like environmental factors that could contribute to schizophrenia. So it's a bit of a mixture of everything. And here is the part that I love. So treatment. How do they treat schizophrenia? So before the 1950s, which was before like pharmacotherapy, before all the medications came about, a lot of schizophrenic patients were treated in mental institutions by being restrained if they were like heavily agitated, or what they would do is that they would administer insulin to lower their blood glucose levels, which would put them in like a state of insulin shock that could last for about an hour. Another form of treatment was electroshock therapy, which is also known as electroconvulsive therapy, or ECT. And it's now very, very rarely used for schizophrenia because they used to believe that by inducing seizures, they could prevent psychosis. So that's a very interesting history. Another thing that was used before was the frontal lobotomy, which I'm sure a lot of people are familiar with the lobotomy and can understand why it's no longer used. But there were about 40,000 that were performed in the US before it was banned. But this procedure was going on up until like the 1980s. So what they used to do is they used to separate the frontal lobe from the rest of the frontal cortex, and by cutting it with knives or by destroying areas with ice picks behind the eyes. So you can just imagine how that must have been. So thankfully that procedure, I should say, has been banned. Yeah, oof. Okay, so then, like I mentioned, this was before like the 1950s, before we had pharmacotherapy. So after that, after the 1950s, that's when pharmacotherapy was introduced, and antipsychotics have been used to treat schizophrenia. So there are a lot of different medications, I will say, that are used or have been used in the past. So I'm not gonna include all of them because that is also another entire conversation on its own. But they do include, and hopefully I don't mispronounce these medications, they include phenothiazines, non-phenothiazines, which was like the first generation of treatment. They used to block dopamine. There's a new generation of atypical antipsychotics, and this includes Abilify, risperidone, clozapine, and these are more effective in treating some of the negative symptoms with fewer side effects. So clients who respond to medication can vary, but they can they range from like 60% to 85%. And one thing to note too is that medication is not gonna cure everything, right? I mean, there's no cure for schizophrenia, so it's not like, you know, you give them a pill and they're gonna be better. There are also this is kind of like my bread and butter, also like different forms of therapy that are used to help people be able to manage the symptoms of schizophrenia. So there are several different ones that are used. The one of the primary ones is cognitive behavioral therapy, or it's also known as CBT. And that's usually what's recommended. There's a lot of evidence backing the efficacy of it, along with psychoeducation and receiving specialty care to help them manage like the first episode of psychosis. But there are also other forms of therapy. REBT is another one, and ACT is growing in popularity. So I don't expect you all to know what all of these therapies are, so I'm going to give you kind of like a little breakdown of what they are. And again, these are not the only forms of treatment that are used. These are just some of the ones that have been used, and I'll kind of explain why they help. So the first one I mentioned was CBT. So CBT is a very popular form of therapy. It is used for a lot of different conditions. But let me just preface by saying this. There's not one form of therapy that's better than everything else. There are so many different interventions. There's so many different theories. You know, some therapies may not particularly work well with some conditions, some others do. So it's not like a one size fits all kind of thing. But you know, something like CBT that is backed by a lot of evidence, there are still a lot of interventions that kind of branch off of CBT. So there's a lot of different kinds. Like when I first realized how much there was, it was like making my head hurt. I was like, how am I supposed to learn all this? But CBT is okay, train of thought. Okay, so CBT, if I'm gonna put this in like simplest terms, the interventions have to do with our thoughts and our behaviors. Okay, so which is like, that's the thoughts is the cognitive process, behavior is a behavioral process. So this form of therapy can help people learn some skills to be able to reframe or manage like your thoughts and behaviors. So that's kind of how the process of change occurs. So CBT doesn't, it's not the same as like traditional psychotherapy where you're like discussing your past and you're focusing on your past and you're moving from it that way. CBT is kind of more in the moment type thing. Like you're identifying your thoughts and your behaviors, and you're learning skills to be able to manage those thoughts and behaviors to have a more positive outcome. And so that's kind of like the simplest way that I can explain that. The next one is REBT. So this is Rational Emotive Behavior Therapy. This is one that I find very interesting, and it's a theory that I definitely have been wanting to learn more about. So this theory is based on how our thoughts, feelings, and behaviors are all connected. So if one of those is kind of thrown off, it means that it'll sort of throw everything off. So they all kind of work together. And in this form of therapy, clients can start to develop like a more rational philosophy that will help them reduce their emotional distress. So things like negative self-talk or behaviors from that, like you start to kind of develop your own philosophy that will help you lead a more happier and fulfilling life. And this theory is also known for the ABC model. So what's interesting is a lot of like organizations actually kind of use this model when they do. I don't know if like where you guys work, if there's like a any kind of like employee wellness course or training or whatever that you've had to do, but I know that we had to do one, and I was like, oh, like the way they were explaining it, I was like, this is REBT. So it was really interesting to see. But it's known as the ABC. It's known for the ABC model. So A is like the activating event, B is a belief that somebody holds about themselves, and then C is a consequence of that belief. So they're all kind of connected. So you have the event, what you know, your thoughts that come from that, and then the consequence of that. So it could be either positive or negative. So that's kind of like the basis of what REBT is. And the last one that I mentioned, it's slowly becoming one of my favorites too. Actually I've actually written some papers and stuff on this form of therapy because I kind of really like it. So it's known as ACT. So this is acceptance and commitment therapy. So it's kind of like a new wave of therapy that branches off of CBT. So like I mentioned, there's like a lot of different interventions that have sort of branched off of CBT. So there's some similarities, but it's also very different. So the difference is that ACT helps people to engage in more meaningful ways in their life, and it also helps them to learn and oh, hello. I think now I'm here. Well, welcome. So CBT helps people kind of engage in their lives in more meaningful ways and learn to accept the circumstances that they're living with. So this it's actually growing in popularity, and there's like more and more evidence that's coming out that it is very helpful for people, especially who are in psychosis, because instead of just being told like, you know, your behavior needs to change, and not that I'm saying that, you know, something like CBT is negative, or it's, how do I put this? Not that I'm trying to say that it's like you're shaming somebody for that. CBT intends to shame somebody for their behavior, because that's not what it does. But the reason that something like ACT works in some ways, can work better than CBT, is because instead of telling people in psychosis like, you know, this behavior needs to change because it's not in the baseline, you know, especially if you're dealing with something like hallucinations, delusions. So ACT kind of helps the clients engage in more meaningful ways to understand the circumstances that they're living with, because something like a hallucination from their perception is very, very real, right? So they learn to work with that, versus just trying to fight against it and trying to change that behavior. So that's one of the reasons that I really like ACT. You know, I've done a good amount of research on it, when it, you know, with several assignments that I've had, and I think one of the reasons that it does help is that it helps people with psychosis be more present in the moment, which also helps some of the negative symptoms that we were talking about, right? So just being detached, not really wanting to engage in behavior, some of the I can't think of the word, some of like the, not assignments, but like some of the things that you would do in therapy with ACT can sound very simple to kind of any population that's not in psychosis, but it can be as simple as like you give somebody a tangerine and they are focusing on, you know, when they're peeling it. So you're really focused and engaged in the moment. You're talking about the texture, like how you peel it and things like that. So there would be exercises like that in ACT, and that can help people with psychosis because you're helping them zone in and focus in on the moment. So I hope that makes sense. I know it made sense to me. But I hope I didn't ramble on, and I hope that that made sense. So that's why that, this form of therapy is something that I really like. I really like a lot of those like mindfulness based practices where people are learning to be present. I think it just helps a lot with introspection and well, learning about yourself, being aware of your environment. I think it just helps with awareness, and I think that that can also help you be able to identify and manage a lot of your emotions. So, those are just a few of the different types of therapies that have been utilized, with people who have schizophrenia or, people in psychosis. So, I also wanted to talk about some. This is what I was saying, that it's kind of like the extra little nuggets of information that I've kind of acquired. So, something that always stuck with me when I started learning more about schizophrenia and diagnosis is that Black communities are actually diagnosed with schizophrenia at much higher rates than white communities. So when we're talking about the schizophrenia spectrum, so this includes all of the other conditions that I was talking about before, they can be diagnosed at a rate that's 3 to 4 times higher than their white counterparts. And for schizophrenia alone, they're diagnosed usually 2.4 times more than that. So this impacts Black communities a lot more because once they start experiencing symptoms, there's also a greater likelihood that they'll have, if they come across with law enforcement, they're going to have additional contact with law enforcement. And, the negative stereotypes aren't of any help. And I think that that's something that we should all be aware of. That is the way society is. And, this can be a whole discussion on its own as well. But the truth also is that when we look at empathy and how people empathize, people tend to empathize a little bit better with other people who are more closely related to them or are more similar to them than people who are different, right? And there was actually also some brain imaging that showed that a lot of white people believe that Black people have a higher threshold for pain. So this also doesn't help with that, with the empathy. And I don't know if any of you if you watch stuff like a lot of content that people put out there, a lot of stuff on like TikTok. There are a lot of Black doctors too who are talking about how what a common misconception from a lot of white people is that Black people have thicker skin, that they have like more dense bones, that they have a higher threshold for pain. When that's ridiculous. Like, we're all human, right? So, it just kind of goes to show you, the misconception and how that can affect somebody, not only from like a mental health diagnosis, but just even law enforcement, and even just the medical treatment that they receive, because it's not good to have medical professionals that are thinking like, oh, they can withstand more pain simply because of the color of their skin. So those views like affect this population a lot more and in many ways in society. So another issue is that when it comes to diagnosing Black clients with schizophrenia, some of the things that have occurred in the past is like their emotions are also misconstrued. So if a Black client is feeling something like sadness, sometimes a clinician can see it as madness instead. And if a Black person is afraid, they can be seen as paranoid, which those are very, very different emotions. So that just kind of speaks to the lack of understanding, lack of empathy, and I'm willing to even say like unprofessionalism and unethical practices from clinicians who do that. So some of the other reasons that Black people are misdiagnosed usually includes also their healthy suspiciousness or trust levels. So in talking about just this kind of like marginalization, everything that they experience at all different levels with law enforcement, with medical treatment, with lack of access. With that is naturally, I think naturally going to come, lack of trust with any kind of practitioner, any kind of medical personnel, or even like clinicians in mental health. So, clinicians have to work more to gain somebody's trust if they're truly wanting to help them. And that's the way I see it. And I mean, that's also what everything has taught me in school so far, right? Which, I mean, if you're in the business of helping people, you should take the extra time to gain somebody's trust. So there's again that healthy suspiciousness, trust, implicit bias, not receiving thorough assessments, be denied interpreters if they need them, misdiagnosis due to religious beliefs. So an example of this would be like, if a Black client talks about hearing the voice of God, this is very different from an auditory hallucination. This is not an auditory hallucination. This is a religious or spiritual belief, which I kind of discussed that a little bit earlier on when we were talking about diagnosis. So it's very different for somebody to have an auditory hallucination than somebody to say, I hear the voice of God, right? So just those misinterpretations that come from a clinician that in their mind justifies a diagnosis. I think that that's very unethical practice, if I'm being honest. So those are some of the reasons why they have been misdiagnosed in the past. And additionally, sometimes there's also over medication because of negative perceptions. So it's a form of control when Black people are stereotyped as dangerous. So those are a lot of considerations that need to be made, especially with I'm willing to say with, just even populations of people of color. But, the reason I focused in on Black communities is because of the higher rate. So, we talked about for schizophrenia alone, they're diagnosed 2.4 times more than white people. And then another thing to kind of keep in mind too is that Black people are more vulnerable to schizophrenia spectrum disorders because of just, higher rates of PTSD and trauma, which includes the marginalization that we've been talking about, but then also, a lot of things that go on in society, such as like neighborhood conditions, higher rates of poverty, deprivation of food, services, all of those things. So all of those things are interconnected. They affect people in their day-to-day lives, but as well also, their interactions with law enforcement, medical treatment, diagnosis. So those are all things that are very important to think about, and that me as a future clinician, I'm going to make sure that I keep all of these things in mind, because I don't want to contribute to that overdiagnosis or misdiagnosis. I want to make sure that I treat people individually to the best of my knowledge, and if I don't have the knowledge, that I make sure to refer them, or that I do my own research and have that knowledge. So another reason I wanted to kind of focus in on those last points and last final thoughts that I have is because I think even just sharing the information is a good way for people to pass on that information. So, for example, like if you're listening and you're not going to be working with these populations in any way, so you're not going to be like a nurse, a doctor, you're not going to be in mental health, even if you're not in law enforcement, it's still good information to have, because you can still educate other people about it. Or if you know people who could be impacted by this. So, you have Black family members, friends of friends. Sharing this information is very valuable because I think it also helps them be able to, what's that word? What's that word? Advocate for themselves when they seek treatment. And yeah, I mean, even if for example they go see a mental health therapist and they want to give them a schizophrenia diagnosis, it's a way for them to also kind of empowers them to say, no, I want a referral, or I want a second opinion. So I just think it's good to be able to share that information and just be aware of how our society is. The reality is that it is very messed up, So that's the reason that I think that it's important to kind of discuss all my final notes that I had, things that I've learned. But yeah, I again, like I said, I have a link to my resources as well if you want to look at any of those. A lot of those are textbooks, very expensive books. I highly doubt you'll even want to spend money on them because everything is so expensive. But if you're curious to know where I got all my information, I'm keeping a list of that just so, also to hold myself accountable too, right? I want to make sure to give that information as well. But I wanted to also show you guys, this book has been amazing for me. So I already showed you the DSM, but this book is my psychopharmacology book. And there we go. I was like, where's the camera? So this book has been so amazing because it takes such a complex subject, the brain again, which is so hard to learn. Like, when I took psychopharmacology, I was in tears, okay? I'm not ashamed to say that. I was in tears. So it really like broke it down and simplified, because it talks about medications and it explains like the history of medications, what kind of conditions, they're used for, why some help, why some don't, all that kind of stuff. So yeah, I'm going to be using a lot of my textbooks when putting together a lot of the information. So yeah, I just thought I would share what those look like.